So welcome everybody to this Surginar, which is our signature webinar. And in this, we are going to be showing you live surgeries by three surgeons from Dr. Gaurav Luthra's center. Dr. Gaurav Luthra, of course, needs no introduction. He's a world-renowned ophthalmologist and does state-of-the-art surgeries. And he, along with his two other surgeons, Dr. Gyanendra Vikram Singh and Dr. Amardeep Kaur, would be demonstrating surgeries to you. The surgeries are all done from Drishti Eye Center at Dehradun, and I have with me my co-moderator, Dr. Merle Fernandez, who again doesn't need any introduction. Merle is at the helm of affairs at LV Prasad Eye Institute, Hyderabad. And so I think without much ado, we would start this Surginar. And over to you, Dr. Gaurav Luthra. You can tell us how you have planned these surgeries.
Thank you so much, Dr. Namrata. And at the outset, thank you so much for giving us this opportunity from the AIS platform to showcase some of the surgeries from our center. And we have, planned a few surgeries, and we wanted to showcase at least, a few things out of the usual and the ordinary. And as always happens, and although the format today is of a deferred live surgery kind of a format, so that's, how we are going with the flow of how things should be done today. So we've recorded our surgeries just an hour or two back, and we've kept unedited total raw surgeries for you. And I'll be doing two cases, and then Dr. Amardeep and Dr. Gyanendra, who are also very prolific surgeons from our institute, they do high volume cataract. They will be showcasing. We are also going to showcase some of the new technologies that we are using at our center. And, to be more kind of clear with it, we are going to have, we've had a not a totally uneventful OT as we would have, done if we wanted to, but we have actually gone on and showed challenging cases, which will be all having, it's like real time. So it'll be very interesting for the audience. And we've kept actual situations of what we dealt with today. And we've not kept any of those cases which were absolutely clean. We've only kept those 2 or 3 cases which actually had some events happening during the surgery. And that will be the learning point. So I think we can start off. I'm going to show the first case. Some of the technologies we are highlighting today include a new upgrade which has come on the Femto assisted cataract surgery platform, the 6th version OS on the Catalyst femtosecond laser, where there is now iris recognition and there is iris registration, which we have been using now for the last month or so, which allows us to do toric alignments and LRI planning real time on the machine itself. And we take data from the ILMaster 700, and we can use that for customizing our astigmatism management on the Catalyst, which has been really useful. And we'll also be showcasing some of the things we've been doing on the Veritas, which is one of the newer platforms from Johnson & Johnson. And we are going to showcase some of the unique abilities of working at lower IOPs and pressurized control systems. Anyway, so I think our first case is actually a young gentleman. Can we have the first slide, please? We can start sharing the. Can we share the Namrata? You can hear me?
Sorry, sorry, I was muted. Yes, please share.
Sure. We'll just share screen with our first case. Can you please put it on?
Yes, ma'am.
Sure.
So I think our Surginar series has been a tremendous hit, because it started with the surgeries which are actually performed by the surgeons, and on the laptop online. And so many people cannot actually visit some of the very big centers, some of the good centers, some of the very good surgeons. But those logistic issues are actually no longer obstacle to learning and education. So Dr. Gaurav is director and head Drishti Eye Institute, Dehradun, with special interest in laser refractive surgery, challenging in pediatric cataract surgery, as well as keratoconus. He's the chairman of the ARC committee of IRSI, and also the past president and founder member and honorary fellow of the World College of Refractive Surgery. He's been awarded honorary FICO in cataract and refractive surgery by the All India Ophthalmological Society. He's done over 300 live surgery demonstrations, and to his credit, has 7 orations and 4 named national awards.
Thank you, Dr. Namrata, for that kind introduction. And so we have this patient who is an 85-year-old male, and he's come with complaint of blurring of vision in the left eye. He's a known case of hypertension. He has had in the fellow eye multiple anti-VEGF injections and is stable now. And he's looking for the surgery in the fellow eye, which is the good eye, and he wants a good intermediate vision also, along with without compromising his night driving. It's an elderly couple, but he drives himself. So let's see his data. Can we go to the next slide, please? So he has in the right eye 618 vision, in the left is 612 parts, and it's a poorly dilating pupil in both eyes. There is more significant cataract in the left eye, and it's a PSC plus more significant as well. A scarred CNVM in the right, but we've been able to preserve his vision to a 618 in the right eye. His speculars are okay. Can we show the next slide, please? So that's his image of his pupil doesn't dilate more than that once we dilated him in the OPD, and that was about a 3.5, 4 mm. Can we go on? So as you can see, the right eye, you can see the scarred CNBM, and in the left eye, the macula is better, much healthier, but not pristine. And at 85 years, this is the best that we can expect. So definitely, he's not a candidate for any kind of a trifocal or a multifocal lens implant. So we decided to give him, but he still wanted intermediate vision. So we had to choose a lens accordingly. We'll see what we chose. Can we go on? That's his specular counts. Can we go on? So that's his biometry for the left eye, which is the one we are planning to operate. And we've done a toric calculation. He seems to have significant astigmatism. And we decided that we wanted to use a pure C or an iHands because these are the two good lenses in my hands which work best for patients with some kinds of retinal or macular pathologies, and they still are no nonsense lenses. And the pure C especially has been a game changer for us as far as intermediate and good quality distance vision and tolerance to small refractive errors is concerned. So as you can see, the T-cone and the Lenstar case are both looking similar. Can we go on, please? So on the Almaster 700, because we tend to check on 2 or 3 devices when we do toric calculations, they all seem to agree. Can we go on to the next one? So this is something that we use now, and it's our in-house innovation. We take measurements on 3 or 4 devices. For example, we also use the Anterion or the Almaster 700, the Lenstar, and maybe the iTrace sometimes. And we put all the toric calculations on one sheet. And you can see that they're all looking like the astigmatism is in the range of 2.6 to 2.7. And also the axis that they're predicting is very similar, the axis of astigmatism. So this gives us peace of mind. Now, if we start seeing outliers here, it immediately kind of puts us on, so my staff would prepare this, and this comes to me when the patient sees me for his lens planning and after the biometry. And if I see big disparities somewhere, we would probably want to recheck and look at the topography and other things if we want to change. So since they all agree, we are going to choose a 375 lens at about 180 degrees with a 23.5, which is for the pure C, aiming for the first myopic thing about 0.2 or 0.3 myopia. Can we go on, please? So let's see. Let's start with the surgery, please.
So when you have multiple options like you showed, Dr. Gaurav, which one would you select? I mean, what made you select IOL Master and not the other devices?
Right. So typically what we do is, can we pause it for a moment? So typically what we do is, most often what happens is the axial length is always going to be almost exactly the same on all the devices. It's basically the keratometries which are going to differ a little bit. And then you have to see whether, for example, the T-cone is very good. It's a topography thing on the Lenstar, which gives us better for the axis. So we trust T-cone more for the axis rather than for the magnitude of astigmatism. But usually what we've seen is that in regular corneas, there is not a huge difference between the case on these 3, 4, 5 devices. In fact, we also do a Virion. So actually, I have about 6 devices doing the keratometries and giving me. So usually what happens is I will see agreement between at least 3, 4 of them, and then I'll go with that. There will be 1 or 2 outliers, but sometimes if the cornea is irregular or if there is some irregular astigmatism or if, there's something which is, we would repeat these measurements. And typically we would go forward with a toric. Sometimes we've seen that, there'll be very funny axes. One is telling 53, another is telling 72, and a third one. This typically happens with very small astigmatism like a 0.5 or something. There we may sometimes decide not to even use a toric if we are not able to get consistency between devices. So that's how we do it.
Question for you, this is mainly for the audience, Gaurav, is what is the minimum amount of astigmatism that you would do a toric for?
I do a toric calculation for all my patients, and irrespective of what astigmatism they have. And if I'm getting a predictable toric of the smallest value, for example, a 100 or a T2 or something, I will correct it. And I don't I would use a toric for every patient if I had to. If it shows up as requiring one. Of course, if many times, the Almaster or the Lenstar will show that you just need a 0.5 toric, which is obviously not available. So I can't use for something like a T1 or a smaller than 100 on the J&J platform. I would not use it. But if I'm getting a consistent measurement, especially we do the total case on two devices, we do them on the Anterion and the Almaster 700. So we do have very good quality keratometric measurements. And if all of them are showing that it needs one, I will not hesitate to use it using the Barrett's nomogram or total case.
Okay. And so do you also do a pentacam or some kind of tomography to correlate
For
the amount of
not for all our patients, not
Okay.
for all our patients, but for post-refractive surgery, yes. For all post-refractive surgery patients, we would do that. Or if there were corneas which were, haywire for some reason and which are not measurable on these devices, I would definitely. Pentacam is very versatile for very flat and very steep corneas, and then the EKR report becomes very useful in those abnormal corneas where it becomes. Then I would do the pentacam, but not for all my routine cases.
Okay.
But we do topography on 3 devices as well. We do on the iTrace, on the Lenstar, and as well as on the anterior derived corneal measurements. So we have access to those when we are looking at that. So should we go on? Can we play the surgery, please? So this is probably going to be one of the cases where we did have as I said, it was an eventful case. This is the gentleman which I just spoke about, who's an 85-year-old gentleman having a smallish pupil which is refractory. And I'm using these calibrated blades, which are exactly 22 gauge. They're made by Orolab. I have no financial interest, but they are very good because they're angled and they will, they have a guard. So they will make perfect side port incisions, which are calibrated to my bimanuals as well as to my instruments so that my wounds are not leaky. So when I put my instruments, then these incisions are all calibrated. So here we are using Helon GB, and I'm trying to see if that helps me do viscomydriasis, but it doesn't make much of a difference. And now I'm ready to do. So we decided that we wanted to put a Malugins ring. And as you can imagine, when there is a live surgery, my assistant very nicely, I asked him for the Malugins ring. He gave me the injector alone. He took it out of the pack and handed me the injector. And I said, what am I going to do with this? So when I went and put it back to load it, the injector actually caused one of the, twirls of the Malugin ring got distorted. So when we try to reload it, re-engage it. So as you'll see just now, when the Malugin ring delivers, everything will be nice except the trailing, twirl of the Malugin ring. It got distorted and it was a challenge to put it. Also, I realized that the fact that we had used Helon GV, that's a very heavy viscoelastic, and you can see that the Malugin ring is a little distorted. So if you can see even the two side ones, they got a little twisted when we loaded it again because he had already disengaged the Malugin's injector from the Malugin ring. So if you look at the last twirl that I put in, it seems to be distorted and out of shape. So what happens is that when you put a very heavy viscoelastic, your iris is plastered against the lens. So you can see that my manipulator is almost touching the anterior capsule. So I'm finding it tough to actually put it under the iris. So I'll have to either lift it up with a manipulator or inject some viscoelastic under it. So I'm going to go from the side port and then ensure that the Malugin's ring is inserted properly. This is under topical anesthesia, and we've used intracameral lignocaine for this gentleman. So I'm lifting it up and then managing to get it under it. The other way would have been to put a little bit of viscoelastic and let the iris lift it up a little bit. So again, here it will be a challenge because the iris seems to be pushed nicely against it, and my Malugin's ring has got a little distorted. Otherwise, it's not difficult to put it in. So as the Malugin's ring got twisted in that in its container while I was trying to load it, which almost has never happened to me. But as I said, in live surgery, everything happens which normally doesn't. And I was thinking that when we do this deferred kind of a thing, it'll be a very boring affair. But frankly, even the deferred live surgery format, we found that it was very different from our usual, seamless OTs, and it was interesting. So you can see that now we have the three, things engaged over there. Now the fourth one is going to be a bit of a challenge because if you'll notice just now, it has got nicely distorted while my assistant loaded it again from the, the injector. He put it back and he managed to catch it the wrong way, and then it got distorted. So you can see it's twisted, but it was still usable. So I'm going to pull it in. And a bimanual approach is always useful. I sometimes use a forceps also. I use the glue dial forceps sometimes from the side port and hold this and put it, especially with the B-hex, which also I use quite often. I use the glue dial forceps or the B-hex forceps to insert this last one. You can see I'm struggling a little bit. I don't want to damage the entire capsule. So I'm using bimanual approach. I have engaged it with my Y-tip manipulator. And with the other one, I'm going to just move the iris away and lift it up and then let it ease under that. But because of the distorted shape of that Malign's last, so that's how I managed to get it under the iris. And then things were much better. But see, it was jutting up. So, and that has come right under the main port. And so I'll have to be a little careful when any of my instruments goes in or out of the main port. So we are all set now. And you can see that I have a fairly sized pupil now. And another thing I realize right now is that, it's so easy to edit videos and show them. When you have unedited, then it seems painfully slow. But that's the whole idea of, deferred live surgery. We didn't want to really edit our videos and show them in real time with all the real complications that we face during the surgery.
So normally when you would use a mannequin ring, Gaurav, do you reuse it again? Because I know that people
You
do
can
use it
one more
again.
time, I think. What happens is that they've changed the quality. When I used to use it like 10, 12 years back, see, Boris used to be in my course for almost 10, 15 years, and they used to make the ring much more sturdy at that time. But when they came to the Malogin's Ring 2 second version, they made it much more friable. So while it works beautifully in the first one, in the second one, it works only okay. So we ETO it and use it. But beyond 2 uses, I found that the material degrades and it becomes difficult to reuse it beyond 2 times. And it is quite expensive, frankly. So I reserve it for all my most challenging situations. Most of the small pupils I actually manage quite well. If it's a 4.5 mm pupil, I'll just manage with phenocaine kind of a thing, or similar, and maybe sometimes an iris hook. But Malugins remains like one of the safest options for situations where it's a complex surgery and you want to do everything right, and a no nonsense kind of a surgery. I think even a B-hex in some people's hands works beautifully. I've seen excellent videos. I use the B-hex as well because it's much more economical and works well as well. So where I'm trying to rotate, it's not a very hard cataract, and it's a sticky kind of nucleus. And I'm trying to just make sure that we are, freeing it up. And we use the Callisto or and the Virion both. And we typically mark before we start the surgery, because we do the registration with the Callisto, because what we realized over the years was that if you don't put these check marks, sometimes towards the end of surgery, because of the small 1 or 2 hemorrhages which are there, the Callisto or the Virion can start showing the axis off by a couple of degrees. So here I wanted to be very careful, because I put in good amount of viscoelastic to deepen the chamber, because you can see that it's catching the Malugins. So I'm going to lift up a little bit and enter with infusion on, and because of the heel on inside, the chamber was not getting distended as it normally does with when you switch on the infusion. And my infusion pressure is not much. I'm using a bottle height of only 50 centimeters, which amounts to maybe a IOP of about 35, 36 IOP. And this is on the Veritas. The Veritas has been amazing, and I use the Centurion also on the other OT. But the Veritas has, taken a big space in our setup. Almost all our surgeons love the Veritas because we can operate on very controlled IOP. So you can see I'm trying to do a direct job, but it's a friable kind of a cataract. So, it doesn't give me a great hold and it just disengages. So this is a common problem that some of the surgeons who maybe beginner surgeons may find, that if they don't get a good hold, they might want to increase the energy. But frankly, increasing the phacopar makes it worse because you eat through it. So if you miss at one point, then you just need to embed right in the main chunk of the nucleus, right in the middle. That's where even the soft cataracts will have some amount of firm nucleus right in the middle. And so you embed there, get a good hold, and then while you get that hold, you can just embed the chopper and see if you want to do, because the central crack does not work here very well. You can go and do a little bit in the periphery under the rexus, and I've managed to get one crack there. And now I'm going to go rotate it and try to get a few more cracks. So I'm doing a direct chop. If I run into trouble in those rare cases, like a very hard rock brown cataract, or sometimes even a soft cataract, I can convert it into a softened chop. So here we are rotating the nucleus, and I didn't want to fast forward it at all, because this conveys, for the surgeons who would like to really see a live surgery kind of a thing, they would probably appreciate this more.
So this cataract is actually harder than what you anticipated, isn't it? Considering that the vision was also
Right, right. But because the age was 87, so
Oh,
we
yeah.
knew that it can't be a very soft one, but it didn't turn out to be as hard as I thought. It was actually, I thought that at 87, I might actually, because the pupil was not dilating, and I thought it was more a nuclear cataract, but it turned out to be a little softer actually than I thought, because I was anticipating actually a slightly harder one, but it was okay. It was neither.
Dr. Merle, what do you, I mean, would you in such a case do Malugan or PHEX or nylon hooks?
So it depends actually. So sometimes, like he was mentioning, with phenocaine and viscodilatation, you can get away with phaco directly, even if it's a 4 pupil. I think the patients who have senile meiosis, where the pupil doesn't dilate beyond 3, those are slightly challenging. I haven't, frankly, used the Malugan ring, and usually I'll just use the iris hooks.
Mm.
What's your favorite, Dr. Namrata? Like when
So,
you're
I'll tell you why, and I mean, nylon hooks mainly for economic considerations. I was talking about reusing the Malugan ring, which, we were using earlier, and I know that we could ETU and reuse it up to 3 times as well. But now, of course, you can't do it. So, and of course, but the fact remains that when you use nylon hooks, then you do have to give 4 side port incisions and you know put the hooks and then take them off. But this looks pretty good. The only thing is that the dilatation is not as full as possibly you can titrate in with the nylon hooks. What do you say, Gaurav?
Yeah.
I completely agree with the hooks. You can actually go all the way. The only thing is, I realize that if you need a 5 millimeter rexis, so this does give you about a 6 millimeter pupil, which is usually enough for us to do a good surgery. Frankly, with experienced surgeons, they probably do even with a 5 pupil as good as with a 6 But yes, where you need a much bigger pupil, for example, if you want to make a bigger rexis and all, then hooks would be. I would say that hooks are the mainstay for majority of surgeons, and this is just something that you should know, because in some situations where you need to use the Malugin's ring, it works beautifully well. So here I'm because my ring is uh, is standing up just near the incision. I want to put in viscoelastic and then come out. So here, oh,
So you're also using Veritas machine, Gaurav?
yes. And Veritas has been, a very good upgrade to the Signature Pro. It has dual pumps. It has a, Venturi. And in fact, for my quadrant removal here, I was using the Venturi pump. So for my cracking and for my embedding and cracking, I was using the peristaltic pump. And for the, the second part, like the quadrant removal, because I needed, good kind of flow. So I was using the. Can we take it back exactly to that point, please?
So
Yeah.
I've been using the Veritas, and I too enjoy working with the machine. But I've been using Venturi throughout, so I don't actually switch between peristaltic and Venturi. So I find that for harder cataracts, the holdability is really good, and it remains rock hard. Whatever you're doing, that nucleus doesn't move, it doesn't slide. So even if you're doing a very brown cataract, you get a very good grip with the Veritas. I've also used Quotera and Centurion, and we alternate between those machines in different theaters. I mean, they're also equally good. I have no financial interest in either of them, but I like the feel of this particular machine.
Also, Dr. Mal, if you've used the, and Dr. Namrata, if you've used the new packs, on the Veritas, we started using these new packs about a month back. And we've really enjoyed it because it's given us this new capability of good IOP control and pressured, infusion. So even with bottle heights of just about 20, we can add almost 30 to it if we need to. And because of their pliability and, the surge and everything is much less. So I have actually noticed a significant difference once they gave us, I bought the Veritas almost a year and a half, two back, but they hadn't been able to get us those new packs. But once we got those packs last month, and we've now started using them regularly, I've seen a significant improvement in our, search protection, and it's a little, it's kind of soft on the outside, so it's more pliable and easily manageable, because the previous packs were very firm. So you had to be kind of, sometimes they would put kind of a stress on your when you were holding the bimanuals and stuff. Now that has improved a lot, but inside they are still rigid and nice, and they give us a very good vacuum. So I don't know if if you've experience with that.
No, not yet. So
Can
which
you
is the
dial in?
bimanual that you use? You mentioned that it's a 22 gauge.
Right. So I'm using bimanuals which are actually customized for me, and they're made by Epsilon. I have no financial interest, but they are very finely sandblasted, and they are both my infusion and my aspiration ports, and they are bullet shaped right at the tip, and they are made to 22 gauge. So basically, that ensures that my wounds are non-leaky. And so what happens is, if you want good chamber stability during phaco, you still have a chamber because you're using a handpiece and sleeves which are perfect for your incision size. But when you're doing bimanual, if you have leaky side ports, for example, if you have a 21 gauge or a 20 gauge side port and you're using 22 or 23 gauge, bimanuals, you'll always have, egress of fluid and your chamber cannot remain very stable. So I basically use that so that, there's almost no leaks from my ports when I'm doing the bimanual aspiration. So that helps me. And I can also use them for polishing. So they're very finely sanded. Can we go to the IL injection so that we can move forward? Yeah. So I'm going to implant a pure C here. You can see that the capsule was not very healthy. So I've got a rhexis which is funny looking. I love to have a round central rhexis, but here it was a little bit funny shaped. As long as it's continuous, and this is going to be a toric lens. I see Piyush also. Hi, Piyush.
Sir, good evening.
Hi, good to see you.
Good to see you too, sir.
So now, as I injected the lens, I noticed that my chamber suddenly became shallow, and I didn't want my malugins to get dislodged. So I'm putting in a little more viscoelastic and ensuring that I have a proper fill in the chamber. And now I'm going to just get the trailing haptic. It's a smallish rhexis, and it's a toric IOL, and it's not a very healthy bag, really. So I'm going to just nudge it and put it back into the bag. So the bag was a little bit, loose, and I could feel that my zonules may have been a little lax. So I get the lens in it, and I'm being very, very gentle in rotating the lens also, and kind of nudging both ways and ensuring that I get it on axis. So once I have the Pure C, you will not see anything different on the Pure C because it is made in such a way that the entire surface is exactly the same as the Technis one or the iHands, but they put that special treatment onto the posterior surface where it allows you to give great intermediate vision and some intermediate, some near ability as well. But most of these patients in our practice, we've done about 60, 70 of these Pure C lenses in the last 6, 8 months. Most of our patients, some of them actually didn't need any ad at all, and they are N6, but then majority of them need an ad of about +1 diopter for good near vision. And some of them have needed even a 1.5, but that's like the exception rather than the rule. So once this is in place, now I don't want to do anything else except remove the ring first. And I'll dislodge all the 4 pearls of the Malugin string. And then I'll release them and keep them on top of the iris. I'm going to rotate this so that the ring becomes I don't want to catch that damaged 12 first, so I want to leave it for the last. So I'm just going to rotate it so that that goes to the 6 o'clock position, and I'm able to. So I think I'm going to rotate it now. I was trying to decide how to remove this. I didn't want the injector to malfunction because it's the injector itself which can be used to withdraw it. I thought initially that I can maybe get a hold onto that twisted 12, but then I realized I can't. So it may be a little tricky. And sometimes if the Malugin, kind of gets in the funny way, it can twist inside, it can damage the iris. So you have to be careful that you remove it in the correct way. So I'm just positioning it so that that twisted twisted 12 of the Malugins is at 6 o'clock. So it'll come in last. So once I have this in place, I'm just going to put that injector, which nicely goes through a 2mm incision. So you don't need to enlarge your incisions for that. And I'm going to get it out. So put in more viscoelastic deep in the chamber. And then bimanually, because I want to ensure that this Malugins is a little away, we will engage it. It's very easy and it's very predictable. That's the good part about this. So you can see that small, lock coming in, and it catches hold of that Malugins 12. So you pull it in, and then once you reach these 2, you have to just gently press it in place. That ensures that they go in properly. And then that last one, which was a little twisted, but it still follows. So once this is done, can you just fast forward it by like 30 seconds or so that we can go straight to the aspiration of the vitreal with the viscoelastic? Just about 30 seconds. That's it. Okay, now just let's play normal speed now. So here I'm using this special infusion cannula, which again I've designed myself, and Epsilon again makes it for me. It has a projecting Y-tipped, front, and this, also recently Dr. Kumar made a small variation of this. I've been using this for a few years, and he had an award-winning thing at the SCRS last year for the very similar device, but his Y-tip is probably horizontal, whereas I like to keep it vertical, and this ensures that I can just move the pupil aside in whichever direction I want to, ensure that, especially with small pupils and torics or small pupils with cortex in the periphery, this just moves away the iris to one side. It's very easy, and it also works, of course, as an infusion. So you can see that I'm checking in all areas whether my IOL is in the bag properly, and I'm also going to check. I'm washing away all the viscoelastic and making sure that all is good. Then I'll just switch hands and check whether my other toric mark is aligned properly, and let's see if it is. So I switch hands and then go to the other side, and now I'll just move it to that side, and you can see the toric marks are nicely aligned. So I'm satisfied, and then I will just finish off the viscoelastic, and I'm probably just checking one more time. It works very nicely, and I reserve it for my small pupil toric cases or small pupil cortex extraction cases. Now I'm going to seal, and you can see that on the OCT, we will check whether our incisions are nicely closed. So they'll start looking very nice. You can see it's open right now, but once I've sealed them, then the OCT is, of course, once your eye hardens, you know that, but in some of these cases, if there's a leaky wound, it's very useful to just look at these incisions on the OCT. Especially in my pediatric cataracts, I tend to use the OCT a lot for checking my integrity of my incisions and for the side ports, because if I'm not suturing my side ports, then I need to be sure that they are properly closed. So once I'm happy with that, the eye looks good, and I check the pressure digitally a little bit. If I feel it's a little soft, we also use intracameral moxifloxacin for all these cases, and that's something that we have been using for about 5-6 years, ever since the Irwin study came out, and we've been happy with our rates of very low rates of infections like possibly endophthalmitis. So I think moxifloxacin has been good for us. Any questions, Dr. Mal, from there, and Dr. Namrata?
No, I like that white-tipped irrigation cannula that you use. It's good.
Yeah. Also, see here, I was using this small cannula for sealing the side ports. This is designed by Harshul Tak, and I really like it. I started using it 2-3 years back. It's like a hockey stick. It's just like a small thing. It's just bent like a little bit like this, and you just have to go in, and you can turn it in any direction. You can point it up, you can point it down. So it can really heal. I mean, it can seal it very nicely and effectively, because I used to previously use a thinner, longer thing, and the bend was like much longer. This is very small, so it's just like a small, tip like this. And it just goes this way, that way, up and down. I find it quite neat to use. So it's been good for me. So I think that's done. And I'll go on quickly to the next case if we don't have any question from this one, and maybe we can keep discussing. So initially we were planning to alternate, but because the presentation is probably made in such a way, I'll quickly go on to my next case itself. Now, this is a little more straightforward case, but it was, as I said, not totally uneventful. This is a young man, 33 years old, and he's come with blurring of vision in both eyes, but more in the left eye. He's a high myope, and history of laser barrage in the right eye recently. And this he again enjoys driving, so he wants that his night driving should not get compromised. And he's more of a computer user. And we offered him the option of also going in for it. I've seen that young people do very well with trifocals also, especially if it's a bilateral cataract. But then those who have computer users and who enjoy driving at night, I've now started using the EDOF lenses. And I've again been using a lot of the Pure C in the last 6 months. So let's see, can we go on which lens we chose for this patient? So as you can see, that's his vision. And he has been using a -4, 4.5 diopters. And in one eye, we had a lattice which was lasered. Can we go ahead? We are planning to operate. Now, this was the thing. He had gatte in the cornea, and this was unusual. Although his cell counts look okay, but then we do a specular for all our patients who are undergoing cataract surgery after burning our fingers with 1 or 2 patients when everything looked great. Cornea was pristine, but later on we realized they had a count of just 1,000 or something. So while clinically you can see, so this is on the anterior, and you can see that PSC, which is visible just under the anterior to the posterior capsule. And this was disturbing his vision quite a lot. He was having night driving issues. So he wanted a lens which would be good for his night driving. Can we go to the next slide, please? So the OCT was mostly fine. in both eyes. We do that as a routine thing. You can see that the IL-PAR is a bit on the smaller side, and there's only a small toric. So Dr. Mal, you were asking whether I would still use a toric, and this is one of those patients where it's showing up as the smallest part of the toric. Astigmatism is only about 0.9, and that too at the steep meridian is at the 100 degrees. So typically that would require either no toric lens or a very small part toric. Can we go on to the next one? So again, here, if you notice on the right side, it's suggesting that if I use a 0.5 toric, which of course that nobody makes it, I would still have a residual astigmatism of 0.31. And if I use a 101 diopter toric, I would have a residual of 0.01. So I've decided I'm going to go with 100 because both the machines are showing that I can. And so I've chosen to go with the 100 toric with the pure C lens. So that's our table that we showed you before. And if you notice here, again on the AL master, it shows that between the 0.5 and the 100. So we've decided to go with the 100. Can we go ahead? So I think we can start off with the surgery. Now here I'm going to showcase because we are doing a femto assisted surgery here. And can we go to the femto part first? So there's something new on the femtosecond laser, which I'm really enjoying over the last month or two since we started using it. And that's basically the toric planning and the toric execution and the iris registration and cyclotorsion control, which we never had so far. So this is something which I've been dying to get last couple of years, and it's really changed life for us. And maybe we can just play the audio because I think I spoke on that there. Can you play the audio from there itself? That will be more kind of interesting. So as I was doing the planning, we can maybe get the audio from there. So, very good evening, everyone. Can you increase the volume? Showcasing a few cases on the catalyst system as well as on the cataract surgery with some of the premium lenses. And we have a young gentleman who's got a posterior subcapsular cataract. He's also a myope. जरा और कर दो माइक और उसको म्यूट कर दो म्यूट कर दो म्यूट
सर आई थिंक सो ऑडियो क्लियर नहीं है।
बट उधर का म्यूट कर दीजिए मेरे को बोलने दीजिए
हाँ कर दिया सर।
ओके डॉक्टर नम्रता कैन यू हियर मी
Yeah, we can hear you very well. No
So
problem.
apparently on the feed, they're saying that on the YouTube and Facebook feed, there was no audio. So I think I'll just speak and let's just play this and I'll just speak myself because I think they were not getting audio. Some people gave the feedback that audio is not there. So I'll just speak. Can you keep playing it?
Yes.
Okay, play it, please. Play.
Already.
Okay, so now here we are doing the toric calculation. And you can, as I said, you can use the anterior case or the total case, and you can select whichever one you want. And that gives you the freedom to go by the Barrett's nomogram with the anterior case or the actual measured case, which is from the ILMaster 700. And then once you have that data, you can just apply it, as you can see on that small mark below. And then it does the toric calculation. Then you can choose the optical zone for the toric marks. So essentially what the laser will do is it will put these radial marks, alignment marks for the toric IOL, which can remain even through life. So, the advantage is that on table you will have, cyclotorsion controlled toric marking. So you don't actually need a, a Virion or a Callisto for it. And also these marks can remain through life. So even if you see a patient like an year or two out, you can just dilate and see if the toric marks are aligning with those marks on the cornea, which you could see. And you can choose the zone at which you want to put it. So I'm just playing with the zones over there. And then you can also play with the length of those marks as well. So once I've done that, I will go on to the actual laser. And then this is a young gentleman, so it's not going to be a hard cataract. It's a softish cataract. So we can just go ahead with the laser once all these things have been fed in. Much of it is automated now, so it has made life very easy because all this data got directly imported, including the patient's names, all the keratometry details, and everything got imported straight from the ILMaster 700 and made life so much easier for us. And with the iris registration, it has really changed life for us because now we are happy with all the toric markings, and the LRI planning and the LRI execution has become so much simpler. Then once we have done this, we just cross-check from the biometry whether the toric calculation on the 700 printout is showing the exact same axis as the one which the catalyst calculated. And once we are satisfied that it does, we can just go ahead and finalize this and go ahead with the surgery. So I've just checked that first, and I'm just going to move on now and go ahead with the application of the laser. So can we go to the laser firing part? Yes. So once that is done, we are now going to go and if you look at the top left part of the screen, I'm going to first dock the patient, of course. And this docking is going to happen, adjust the patient's position and then ask the patient to look straight up. And this is the back, which is from the catalyst. And once that is applied, you can go ahead. This we have been doing for years together. It's a very good system because there is a fluid interface, there's a liquid interface, which gives very, very precise. Previously, I was using another femtosecond laser where we used to use a contact lens for the interface, but that would give some problems with the rhexis being, the rhexis would be sometimes not as good as we wanted. Here, the rhexis happens within a second, and it is almost always a free-floating rhexis. And the advantage is that because it happens so fast, even in intumescent cataracts, you can actually have a very good capsular rhexis, and I really like to use the femtosecond laser for these very intumescent cataracts where the rhexis is complete in less than a second. So once that suction is applied, I will be able to show you the next step. Can we move forward by about 10-15 seconds? So there I'm docking where there is nothing very amazing to see, frankly. And can we move it another forward by 5-10 seconds? So there I've got the liquid interface and the dock. I've activated the suction and I've captured the interface, and I'm going to lock. And once it is locked in place, I can then start the OCT, which is going to check It's going to quickly do an OCT of the cornea and the lens and the iris. So you can see the OCT is in progress. And now you'll see on the top left, if you see there is iris registration happening, you can see that it says iris registration calculating on the top left corner. So as the OCT is doing its job, it is also simultaneously capturing the details of the iris and matching it to what we got. So this uses artificial intelligence, and this is what many people ask, that what is artificial intelligence used for in cataract surgery. This is where it is utilized, because it's doing pattern recognition of the iris, and that way it is able to lock onto the image recognition can be done. And you can say it shows a cyclorotation of 5 degrees. So it has locked onto the iris and it says a strong match. So we really liked it. So it's only in about 1 out of 10, 15 cases that it doesn't get a strong match. And this has again made life much easier for us. Now we can just go ahead with firing the laser. And looking at it's showing you the comparison of the two iris patterns, and for you to double check manually whether it came out good. And I think we can move forward from here. And that image on the right side is from the Almaster 700. The image on the left side is from and even though the pupil is dilated, it still manages. I was very skeptical whether, how it is going to catch the iris when the pupil is dilated and when the, Almaster 700 image has a small pupil, but it doesn't matter. And it is able to do that. Can we go on to the firing? And these are the toric marks, which I told you about, which are going to be 2 marks, which it kind of etches into the cornea for us to be using it later. And now once that is all done, we can fire the laser. Can you fire it, please? Yes. So there we have completed the rexes, we have completed the sextants, and then it will do the 2 toric marks, and then we'll be done over here. So generally this is a few seconds. It takes about half a minute. And for my complex cases, I really like to use the femtosecond laser, subluxated cataracts, RKIs, intumescent cataracts, black-brown cataracts. I think it's a game changer and it's a lifesaver. Even pseudo-exfoliation in very shallow chambers, it brings in a big level of safety. So I think let's go on to the second part of the surgery where this part is done. Can we play the second video quickly?
So Gaurav, while you're switching on to that, I noticed that you didn't do the incisions.
I don't now do the incisions, Dr. Mal. I used to do them a lot on my, right when I started doing it. But I feel that, our keratome incisions are so much better. And as I told you, I like to have perfectly sized and placed incisions. So problem is that, when it identifies the limbus, it sometimes is not able to capture the limbus as well as it would. So then you waste time, kind of correcting it for the limbus. Now, once you obviously correct for the limbus, the incisions come out beautifully. But, it takes time. And I used to end up wasting almost 30 seconds to a minute, adjusting the limbus and, marking it correctly, and then doing. Dr. Namrata, and do you use the incisions as well? I mean, I used to use them for a couple of years. I grew out of it.
You talked about another machine, and we have another machine, and we always do our incisions. And you
Right.
worked on both. So how do you? Yeah. So
I think, on my previous machine, incisions used to come out really well. And on this machine also, for the first year or two, I used to see the main port almost always comes out beautiful. It's only the side ports where the OCT guidance is not there. And by the time, it's making the side ports, it does not do real-time tracking. So the side ports sometimes don't come out as well, and they may be, not really at the limbus where I want them to be. They're sometimes too far inside. And then, opening them on my previous machine sometimes used to be a little easier. And on this machine also, I enjoy doing it. But I don't see any value in making my incisions. Frankly, I make much better incisions with my calibrated knives. And they are more beautiful. They are better sealing. I don't know. I have read studies where they said that also there have been some studies which said that if you make the corneal incisions, you do tend to damage the endothelium a little bit near the incisions. Ever since I stopped making them, and I feel that I'm doing a better job just with my keratomes. So I don't know. Yeah, that's my thought. Yeah.
Right. And so have you had any issues with people with very dense arcus, particularly because pupil is dilated and then you have a very dense arcus? Is there difficulty in capturing the iris at that point?
Not so far, because we've done only about, say, 50 eyes so far. And some of them have been patients where there was an arcus, which was significant. But as you brought out, with patients with arcus, sometimes making the incisions is tricky. If you make incisions in eyes with dense arcus, sometimes opening them and, getting the right incision can be tricky as well. So that was one area where I never enjoyed making femto-assisted incisions with the arcus. But with the iris registration, no. As I said, I was very skeptical when we started doing this, whether it's really going to work. But we've been doing a small study, capturing, doing this iris registration and marking the toric marks, and then checking on the callisto when we do it on the microscope. And we found that it coincides almost perfectly every time. So then that's given me some peace of mind that, we are actually doing a good job with the iris registration. So should I go ahead with this one?
Yes,
Okay.
please.
So here I think, okay, for this patient, I was using the 3D system on the, 3D with the 3D microscope. And I'm just centering it properly and then doing the toric check. So that's probably from the 3D monitor where I'm trying to do a focusing and the iris registration. So as I said, I always like to put these check marks. So you can't see the Callisto overlay here because they couldn't get a feed from the Callisto. I was seeing it on my microscope, but it was not visible on the feed which they got for the Veritas overlay. So I put these check marks based on the Callisto registration. And now I'm going to go ahead with almost the same steps with the side ports and the main port. And this was a high myope eye, and it behaved a little differently. So in fact, while I thought it would be the most straightforward surgery that I would show today, but it turned out to be a little more, less uneventful as I would have wanted it to be. And I'll show you why. You can probably see those toric marks on the cornea, which are coinciding with those blue marks a little bit inside, just at the edge of the pupil. Maybe you can appreciate those. And I'm making 2 side ports, as I said, and then going to inject a little bit of intracameral lignocaine from the side port. And I don't put visco at this point. I just put, I just harden the eye with 0.1 ml of lignocaine. That also makes the patient more comfortable and makes the eye hard for my incision. And then I'm making the main port, which is a 2.2. And this is again under topical anesthesia. I like to stabilize the globe with a bud and not with forceps. I don't like to use forceps at any point during the surgery on the conjunctiva because patients usually get pain from that. Here, because if you remember, this patient had a compromised endothelium, I'm going to use sodium chondroitin sulfate. So I'm using viscoat to coat the endothelium. And this really works wonders in these eyes where you need to compartmentalize the eye or where you want to, protect the endothelium and then get the rhexis out of the way. So here I'm operating with the 3D microscope. I find it very nice for these young patients, who are very sensitive to light. Essentially, you can see that we have very good illumination here, but my illumination on the microscope is very, very low. It's so less that the patient doesn't become uncomfortable. This is one of the big uses I've found for the 3D system, in addition to all that else it does, that you can work at very low illumination and yet you have a great, view on the 3D screen, on the 3D monitor. So patient cooperation under topical anesthesia is very, very good when we are doing this. So
Actually, I think sometimes the red glow or the retroillumination is so good that you wonder why you are doing, cataract surgery. And when you actually do
agree.
cataract surgery, you see that the nucleus is hard. So
I
this
agree.
is because the operating microscopes have gotten better.
Also, the depth of focus, Dr. Namrata, you're also using a 3D microscope. I think you're using several of them in your center. And I think the retina people also use it. I feel that the depth of perception is actually exaggerated on these 3D microscopes. So you actually see much more depth on those. And I actually like it because, it kind of enhances the depth perception that you get, especially in those challenging cases where you want that. I don't use it routinely, but I use it for, those cases where I enjoy using it. And
No, but you have to get used to it because sometimes
you
it's
have to, yes.
pseudo depth kind of a thing, and you think it's deeper
Right.
than, So in
Our
the
retina team really enjoys it. And I know that you have been using the MIOCT also for a lot of your work. And I think that again is a very big tool which adds on to this microscope, which helps us. But you're right. You have to keep using it if you want to be able to use
you
it.
have to get
Otherwise,
used
if you
to it. Otherwise, you can.
all the same, I don't think that there is a huge change in my treatment. In your outcomes or in your ease of use. So you can see that, I was thinking that I never get an iris prolapse. And today, as I said, when you're doing, surgery for a life surgery event, then everything happens which you normally don't see. I was surprised when I got this, but it did happen. And then I try to reposit it using my special technique where I just do it with my jet wash, but it didn't go in. And I'm trying to decompress the entire chamber now and let the fluid out so that it goes in more easily. I try again, but it somehow didn't go in. Then I had to just push it in with the cannula itself. and let it, I hate to touch the iris because it brings in pain to the patient, but then I managed to do that. And now you'll just see what happens again. I mean, this was one of the unexpected things that happened, and then I'll just show you. I thought I'm just going to remove this cortex and finish it. So as I go back in to put this bimanual from one side and the other, and you can see that these are those 22 gauge bimanuals, and
For the iris prolapse, you can put a blob of
so you
viscose.
can see that again, it came out again. This means my wound somehow is leaky and maybe it's too short. So again, it's a learning point. Maybe my incision is too short. I normally would have made it a little longer, 2.2 incision, more square. So again, I thought this would be a good point. See how I'm going to manage it now by just hydrating this so that it doesn't leak. I normally have never done this. So today I had to do this for a change. And I thought I must show this to everybody else because I learned from it. And I'm just hydrating it so that now during my bimanual aspiration, it's not going to leak. So this was some kind of a small take home and a learning point for me as well. And now I'll just go on. Can we move it forward a little bit? Just go ahead by about 10, 15, 20 seconds. Yes. So once I've removed much of that cortex and
So suppose your iris prolapse, now you've sealed it, but if it occurs, say, during your IOL implantation, then I think the best way is to put a blob of viscoat over there.
Right. This code compartmentalizes and puts it's like a third hand. It's a magical thing. Now here what I'm doing, Dr. Namrata, I wanted to show this is that I'm now just using my infusion. I'm taking very close. So my infusion is doing two things. If you notice, it's below my aspiration. So it keeps as the infusion is flowing, it keeps the posterior capsule away from my aspiration port. So I'm always positioning the infusion, under my aspiration port. So number one, it pushes the PC away. Number two, it does some kind of a hydrodissection. So as I'm going on loosening up the cortex, I'm letting the fluid flow constantly and letting it flow in that area where I'm using it as a jet polishing tool, which I sometimes show in my videos, and it works really well. So I use this bimanual way of doing it, and you can see that it came out. I didn't have to even switch hands. Most of the cortex was out because I was loosening it and making it loosened up by running the infusion very close to it. And once I've got the cortex out, I'll just do a small polish. You can see that I see this, effect of viscoat, that it causes this posterior, the anterior capsular rim becomes more opaque at the end of any case that I use viscoat. I end up having to polish this always because these cells, they become more opaque, which are lining the backside of the anterior capsule. So I've done that, and then I'll quickly do it on the other side. Let's go on to the IOL implantation. I want my other surgeons to be able to, quickly show their videos also, and I don't want to run out of time. We'll go on to the IOL injection part, and I'm going to use the Pure C lens. I did tell you that I'm positioning it at about 110, and you can see the toric marks over there. And I'm doing a hydroimplantation. This is my usual technique. In the previous case, because of the complexities, I used visco implantation of the lens because it required it to. But in my routine cases, I always do a hydroimplantation. I find it maybe last 7, 8, 10 years, I've been using it. And you can see that the lens obviously doesn't get supported very well because it's a big eye. The lens will sometimes move around. I like to have the lens actually into the bag at that point. But then I've decided at this point that I have to position that lens and let it go in. So I took a pause. I think I was asking for some separate instrument is what I remember.
This case very nicely showed the breathing pupil that you have in high myopes. So
Right.
as soon as you put your irrigation in, the pupil dilates limbus to limbus.
Right.
As the AC becomes shallow, then it becomes mid-dilated.
Right. So you're absolutely right. It's a fluctuating pupil in high myopic eyes because of the whole iris lens diaphragm moves back and it pupil dilates. And then, the moment you switch off the infusion, the pupil tends to come back. And sometimes you'll get a small pupil and all you have to do is move the iris away, the pupil away. The pupillary block goes away. And then, so here I've just positioned the lens. This is all done under hydro only. No viscoelastic is there in the eye. And so these young patients do extremely well with the Pure C somehow. I have now about 3 or 4 patients where we've implanted this in the 30s. most of them are not using any near ad at all. That's the funny thing. In fact, it's my senior patients who've actually required that ad of one. And I don't know if you guys have any experience with this, but this was a coincidental finding. It may be just something which I've noticed, and I don't have any data to prove that this happens. But these are the 3-4 patients where I did. Dr. Mal, you wanted to suggest something?
I was also going to say that I haven't noticed a difference between the younger and the older, but I've noticed that a greater proportion of patients are actually reading N6 as compared to what you would expect them to read N8.
Right, absolutely. So this is a high myopic eye. So I'm making sure, because these are the eyes where the toric lens will not sometimes stay in place. And the most often the toric lens actually, kind of gets misaligned within the first hour or two after surgery. That's the most common time. And here we are quickly going to seal it. And can you just show the last part? I'm sealing it. Okay, this is here where I spoke about the cannula. You can move it around in any direction. This was a leaky wound. So I've done it on both sides. And then I've also done the roof of the incision, which is the most important part to hydrate. And then I'll quickly do the side ports. In this, we didn't have the OCT display, but I was checking these side ports on the OCT as well, and somehow they couldn't connect the OCT for this case. This was the first case that I actually operated upon. And then I'll quickly do my Seedles test. I had described it almost 10 years back. I just put a drop of trypan blue, and that helps me see whether there's a trickle of aqueous escaping from these ports. I like to use it for my pediatric cataracts again, and it really makes sure that your wounds are nicely sealed and all. I'll request Dr. Amardeep to keep her case ready, and I'll just switch off and I'll let her take over in a few seconds. Can you show the last part where I put dye on this? Yeah. So I'm injecting trypan blue. You can see a small stream coming from the side port, and that tells you that it's not perfectly sealed. And I'm going to seal it again now with the intracameral moxifloxacin, and I inject a little bit of moxi also into the stroma. So there goes with the moxifloxacin. I inject some, and then sometimes I put it. But there have been reports of adverse reactions from moxifloxacin, and especially if you put it in the stroma, so one has to be very careful using this. So
concentration of moxi and the volume of moxi both are
right. I agree. So in fact, I've been requesting all the manufacturers who make intracameral moxi to make it to the dilution so that you don't have to worry about diluting it. You can, that's what, Steve Arshinov has been propagating and a couple of the others as well. But none of our manufacturers, and maybe from here, from the AS platform, we can give a message to all our companies if they can make moxi for this thing. So if any questions for me, otherwise I'll pass it on to Dr. Amardeep next.
So we can see Dr. Amardeep's case. Only I want to talk about the lens, a purely refractive lens.
Right. So these are the lenses, which we are using more and more now. A lot of, our practice has gone away from trifocals because these are no nonsense lenses. Their, risk of dysphotopsias and everything has been so less. And patients are actually happy to have quality vision. And frankly, there was one more thing I noticed with this Pure C that, if you have a small refractive surprise by about a 0.25 or a 0.5, patients still tend to get their 6/6 vision unaided. That's something which has been intriguing for me, but then that's what I read up, that the Pure C is actually very forgiving if you have a small refractive surprise. If you have a small hyperopic surprise, that, the central, thing that takes care of the reading part takes care of the distance surprise. And if you have a small myopic, it's also very forgiving. So I think Dr. Amardeep, you can go ahead and I'll pass it on. Come. So Dr. Amardeep is very experienced surgeon at our place. She does mostly glaucoma and cataract and lots of premium IOLs. So I'll pass it on to her.
So Dr. Amardeep Kaur is a senior consultant at Drishti Eye Institute, Dehradun, with special interest in glaucoma anterior segment. And she's basically was consultant and at Ahilya Eye Foundation, KPMI Hospital, and Vasan Eye Care at Cochin, as well as at Berhampur. And I think we'll, without much ado, we will watch her surgery. And she excels in handling complex cases, including flats.
Good evening, everyone. I would like to thank AIOS and Drishti Eye Hospital for giving me this opportunity. This is not a very difficult case, although it's a 64-year-old male, and he presented to us with blurring of vision in both eyes and not significant, just hypertension and asthmatic, and he was on medication and everything was well controlled. So the uncorrected vision was 6/18 and he is slightly hyperope. It was a routine NS1 to 2 PSC. Fundus was normal, pressures were normal, and he had a good specular count. OCT macula was also favorable for the premium IOL. And biometry also showed all of the biometries, they show hardly any astigmatism, around 0.3 with the rule astigmatism. So we thought we'll just go with the plain pure C lens because the patient, he leads a very active life. So he's driving at night also, he's fetching things from the market in the daytime, and wife is a little dependent on him. So he wanted no glare, no side effects of the trifocal IOL. So we thought we'll give him a good vision. And next, please. Yeah, even the IOL master is suggesting like just hardly any 0.23 astigmatism on TK. So toric details also there, none of the thing is suggesting to go for a toric IOL. So we went for a plain pure C lens. Can we play the video?
Yes.
So this is not a very well dilated pupil. Sometimes in the OPD, when we see a patient, we hope that in the OT he might get fully dilated because the drops are repeated multiple times. But when I went for the Rex's marker, the pupil size was exactly 5 mm. So it was not too small to go for any pupil expander. So I was doing it without any iris expander. Although a little deep set eye, I would have preferred to go for the superior one, but just because the deep set in a prominent brow, I decided to go for the temporal approach only. Patient was very cooperative, fortunately. And somehow I've seen that those people who have a tendency for IFIS or poor dilating pupil, I sometimes feel the homide actually helps. So I always put a drop of homide before proceeding for surgery. I've got good incisions. There's a little pooling of fluid on over the eyeball. In these cases, the cataract is not very hard, not very soft. So especially for the premium IOLs, we have to be very careful with the rexes. It has to be a continuous and central rexes so that we can give the best outcome to the patient. Even with the visco, the pupil has not dilated further. I didn't want my rexes to go beyond the pupillary margin, then the cortex removal would have been a bit difficult. So just going along the edge of the pupil.
So generally, you would like to use a cystotome for X's, or you would use forceps?
I prefer a cystotome only until unless it's a mature cataract. Then I go with that small 30 gauge needle. I puncture, drain out the soft cortical material and the milky fluid, and then I put some viscoat and go with the forceps there. I love to see a good hydrodissection because that gives me a satisfaction that during the rotation of the nucleus, during the further maneuvers, the procedure is going to be easy. And I always take the capsular flap before going for hydrodissection. That gives like the chamber is already a little decompressed before going for the hydrodissection. So I'm easily able to rotate the lens. Throughout the surgery, the pupil has remained fixed. So now going with the phaco. We are very happy with the blunt choppers. I don't think for a very long time we've had to use a hard sharp chopper for a very long time now, even for a very hard case also. Just removing the superficial soft matter. Sometimes we don't get the perfect two hemispheres. So, but one large piece that I would like to divide the bigger piece first into smaller pieces.
So, Dr. Amandeep, do you also use peristalsis and then switch to Venturi for
I
the?
still have to try that, ma'am. I'm looking forward to try the Venturi part because in the earlier stage of our FACO training, we were using a Venturi-based machine only. But I'm very happy with the peristaltic one because the AC is very nicely maintained throughout the surgery, not even like slight fluctuation of the anterior chamber throughout the surgery. I didn't have to come out of the anterior chamber and put viscoelastic again. So the whole nucleus was aspirated in one go. The stability is one thing which I like about this machine, especially this new infusion set. Like just that last piece is left, but still the AC is very nicely maintained. And the emulsification is pretty fast too.
So it looks like the pupil has come down further, isn't it? I mean,
Yes, ma'am, because the last piece, it just rubbed the pupil margin. I think that's what caused the pupil to constrict a bit. Otherwise, throughout the time, it was nicely maintained at 5 mm. But again, when I'll go with the irrigation, it comes to the same size almost. Earlier, I used to struggle initially to enter directly with the irrigation mode from the side port. But now what I have started using, I go through the main port with the irrigation on, put the side port so that the AC is maintained. And then I just enter with the irrigation from the side port. Going a little tangentially for the cortex remover, followed by the radial pull.
so your bottle height is 60 centimeters at this.
Yes, ma'am, that's the final bottle height because it's actually 30 centimeter. The additional 30 is given by this new AI pump.
Okay.
So if it is showing 80, that means it is actually at a 50 centimeter bottle height.
Minus 30.
Yes, ma'am. Because most of the time we start our case, like initial cases, we do at around 80 or 100 centimeter. Then for like Veritas now come down to 60 also.
So, Merle, do you think there's a role of low IOP? I mean, having, you think it is what are the advantages you would think? Because when you do have low intraocular pressure, your speed kind of comes down a little bit, comes down, and then, I mean, what is your take on it? Do you think it is beneficial for the surgeon and for the patient?
I don't know. So I don't know if you're going to operate for a long time. I guess maybe if you have lower IOPs, it's going to be beneficial. But frankly, I've not noticed any difference.
Yeah, quite right. Even I thought as much that although they do say that you should operate at low IOPs, but there's not too much of a difference. And I don't think we've done any, subjective evaluation of this from the patient point of view, because it is said that the patient perhaps might feel a little more comfortable
Yeah.
at low IOP. But then if you have AC shallow, which is there, and you work on a low IOP, then of course it's a little tricky.
Mm.
Yeah, ma'am, as most of my patients, they have glaucoma too. So
Okay.
I am more comfortable. That's why to operate on a relatively low IOP settings.
Okay.
And quite a lot of patients are there advanced, like almost tunnel vision. So I'm a bit scared to make the IOP a bit high during the surgery.
But what if they have shallow anterior chambers as well?
And then I adjust it if I'm having a bit problem and I think it's taking too long because that's harmful for the patient. So then I increase the bottle height. It's not very rigid thing, but most of the cases we are able to do with this much bottle height, and the chambers we hardly have any like fluctuation of chamber.
And have you implanted the pure C lenses in eyes which are mild to moderate glaucoma?
Mild to moderate glaucoma, definitely, ma'am, but not in the, never a premium IOL for the advanced glaucoma patients.
So which IOLs you would think you can do? Our challenge nowadays is people are shifting to EDOFs, multifocals, but can we do them in glaucomatous eyes or can we do them in diabetics? What is your
Ma'am,
take?
yeah, ma'am. I think for the diabetics also, because the main concern is that they lose the contrast and all. But with these lenses, the EDOF and the enhanced monofocal lenses, we are getting good results. Even if the patient has some diabetic retinopathy changes also, the patients are very happy with the IHANS. Pure C we have implanted. As of now, we are picking our cases who are absolutely perfect for the macula wise also, because patient is paying that much. So we have to guarantee like you will be getting the results. But whosoever we have implanted Pure C, patients are very happy. Like a patient with a binocular vision of unaided 6/6 and N6 unaided, who has Pure C in both the eyes. And uniocular also, they are 6/6 partial or N6 partial or N8. They're waiting for the other eye.
I think anyone who has got evidence of CSME, any microaneurysms or hard exudates in the macula, I think those are the ones that we should be wary of putting these premium.
Right, ma'am.
Because
Ma'am.
they may be okay to start with, and then gradually, if the retinopathy progresses, their best corrected visual acuity does go down, and then they become a little unhappy with that choice.
You're absolutely right, ma'am. That's why we go ahead for the full retina screening as well as OCT macula for all the most of the patients. We are doing that, and for the especially for the premium IOLs, we definitely. And if the macula is not very healthy, we discourage the patient that you will not get the same output as you are paying for.
Yeah.
So thank you. That was a wonderful live surgery demonstration. Mandeep, you really did a great job, despite the fact that people kept coming down in between. But I think the surgery was very good.
Yeah. Thank you so much, ma'am. Right. I think
we can shift to the next case. I think the last case of the day. So, Dr. Gaurav, can we have
I think Dr. Gyanendra Singh, he is one of our senior. He's also a PICO trainer. He's been training a lot of, before joining us a few years back, he used to train a lot of international fellows from all over the world. He was in Jaipur before, and he's a prolific cataract surgeon. He does, he's a rescue guy for us for all our SICS complex cases also, and he's a very good PICO trainer. So I'll invite Dr. Gyanendra Singh to please come over.
Good evening. Am I audible, ma'am, there?
Yes.
Yes.
Good evening to the chairpersons. Thank you, Dr. Gaurav Luthra, for this introduction, and thank you, AIUS, for providing me this platform first time to share my limited experience with cataract surgery with you all.
So it is not limited, Gyanendra. You have a huge experience, senior consultant at Drishti Eye Institute, worked as senior consultant for a decade and gave invaluable services at SHRC Jaipur. And I think the best part is that you have trained so many surgeons. You've trained more than 200 surgeons from India and around the globe. And I think that is the highlight of the day. And thank you so much for showing us your live surgery. It will be a pleasure.
Thank you, ma'am. Pleasure and honor to be with you. So briefly, because I think there's a time constraint, briefly about the case. A 65-year-old female, no systemic illness, and she was very keen for a good distance vision. Practically, she wanted, I don't want to wear any glasses for my distance vision. So best corrected vision with glasses was 618, and it was kind of a grade 3 to grade 4 cataract. So we did a specular profile, which was good, and OCT macula showed nothing abnormal. So we planned her for toric lenses, and usually we do, like Dr. Gaurav has already explained, so I won't go much into the details of choosing which biometry to follow. So if Lenstar, T-cone, and IOL Master, they are all concurring, and I see around 1.5 diopter of astigmatism with the rule, steep axis being around 100 degree. So we went ahead with this reading only. All three were showing the same. So there are two schools of thought. My talk will be oriented more towards, my kind of students, like I'm a senior student. So the junior students who are going into the toric thing, they are sometimes confused by the schools of thought, what to choose as a post-op residual astigmatism. So there are two schools of thought. Some like to go with the pre-existing degree or maybe pre-existing meridian. But I prefer the other school, which says you go and choose the least amount of astigmatism post-op, which one the power or is giving. Only exception that I follow in my limited experiences with the younger patients, I try to leave them with a little bit of with the rule astigmatism, so that over the years, when there is a shift towards against the rule astigmatism, it shouldn't bother them much. So I think quickly we'll move to the surgery right now. So as previously, we have all seen the surgeries by wonderful surgeons. So I'll be sticking here to few of the steps that I, with my experience, have thought they can be really helpful to people looking for a wonderful cornea and post-op experience on day one only. So this is a very well dilated. Now here, I will like to say that we are using the Altivo system. So I like to mark my axis as well as the main incision before starting anything. And I am not using any marker. What I do is with a 26 gauge needle, I just put a kind of a little, linear abrasion at the limbus. And then I stain it with trypan blue. And when you wash it off, it gives you a kind of a more precise marking of the axis of astigmatism, which we intend, or the planned astigmatism. And I use a kind of a blunt rod to give a counter pressure, as sometimes with the bud, I have seen some fibers, they are, in post-op, you see them in the incisions. And especially if a patient is on blood thinners, then using a forceps can lead to some amount of subconj hemorrhage, which a patient might, complain the next morning that why is my eye red? So it's a retro illumination, wonderfully showing the glow, and it can mislead you to think it's not a grade 3 or 4, it's kind of a grade 1 cataract. But the glow can be misleading. So
Yeah.
after making the incisions, and also if you can note, I don't make my side port incisions exactly 90-degree 180 opposite to each other. I find having my left side port easier to maneuver when it is closer to my main incision, so that I don't have to use much more force while splitting the nucleus. It's more kind of a gentle separation. So the second rod or a iris repositor can also help you to smoothen out the flap without moving much with the cystitome. Sometimes in the beginning stages, you can get this cystitome stuck in the anterior capsule, and that can lead to runaway of the axis. So we avoid using it to smoothen the flap. Then at the marked
That's a very good tweak, Dr. Ganendra, of using the repositor to kind of flatten it out, and also gives you control of the eye while your instrument is inside.
Exactly, ma'am. Sometimes if the patient moves suddenly, you can apply a counter pressure just to keep the eye in center. So when you have available, you can see this is almost after the axis. I am just checking for the size, which the microscope shows me as around 5 millimeter. So then for the starters, you can always keep a memory of this size in your brain, so that even if you don't have a measuring instrument later on or at any particular setup, then you could be pretty sure that your axis is of adequate size. So just a gentle rotation to make sure that the nucleus is freely movable. So now going in with the fluid switched off, it can lead to descemet detachment. So always go in with the fluid switched off. Now here I will be trying a different thing, as contrary to what conventionally I was taught, and I think most of us have been taught, that just crack the nucleus in a center, get nice 2 pieces, and then carry on with the phaco. So this is something which I have been practicing, and it's nothing like I have invented this. So many people practice it, but I find it very safe, especially in hard cases, to kind of crack it in periphery and try to delineate the hard endonucleus. So the reason for that and what's the motive behind that, I will be coming to you in a short while. So here you can see I am occluding in the periphery and I am rotating it. At no point I am making any effort to crack it into the center and make it into two pieces. So once now in this step, you can see when you have that look of the periphery or the circumference of the endonucleus, that gives you a reference point as where to occlude and get this endonucleus free from the rest of nucleus. Because as we know, anatomically, it is the thickest part and it is the hardest part to crack in our phacosurgery. So if in a very hard case, we try to crack it in the center, sometimes it can lead to excessive force, which leads to zonular dialysis, or maybe in worst case scenario, you can lose a whole hard nucleus into the vitreous cavity. So once a 360-degree separation of the endonucleus is done, like here, now you can see that hard endonucleus part is separated. And it's also giving you a feel of the real hardness which you have to deal. Now I am cracking the kind of a horizontal chop going around the circumference of that endonucleus, and I have taken care of it this. Now the question is why I am doing all this when I could have simply cracked it into two pieces and later on into small pieces. See, with an intact nucleus, you have around 2.5 or maximum 3 millimeter of AC depth in which you have to work. Where you crack a hard piece, bring it out into AC, you use phaco, which obviously will be more in a hard case, and the next morning the cornea shows it. So when I have taken care of this endonucleus in the beginning, this gives me another 2 to 2.5 or maximum 3 millimeter of depth in the center. So now whatever pieces I am chopping, I am doing it in the bag. And I'm gradually chopping a small piece and I am doing my phaco under the rhexis margin. So what it gives me is I don't have to use excess force to crack that dense posterior plate or the dense central endonucleus. Secondly, I am so away from the endothelium that even with this grade of cataract, I haven't used any of the denser viscoelastics. So gradually you keep on chipping very small pieces and keep on doing the phaco at a very lower plane. It's under the iris plane. So over the years, what I have seen is that this gives you a kind of brilliant shining cornea on post-op day one. And with the vision, that patient is maybe happy, or he is really, appreciating that even with this hard grade of cataract, I am able to see much better right now. So with hard cataracts, I found this technique, sometimes we can say that as phaco delineation, that we are delineating the endonucleus using the phaco. So once you have taken care of all these hard nuclear parts, then the remaining plate or the epinucleus, which is also not very soft in such cases, that can be easily taken intact. So till the end, we have not make any attempt to crack the dense central plate, posterior plate, which is sometimes, the biggest hurdle we face during operating such cases.
So that is, I think, a different technique of addressing a hard cataract and a new one and a rational one, I should say. But would you do that in soft cataracts as well, Dr. Gyanen?
Not exactly, ma'am, because in soft, it is difficult to go in the periphery, occlude, and kind of delineate the endonucleus. So in the soft, I would like to go with the conventional thing, because in the soft, even if we are doing it above the iris, we are not using that much of phacoparmum. So the cornea doesn't take a hit. So this is especially for grade 3 or brown black cataracts, where, we are able to crack the nucleus, we are able to do a perfect phaco, but somehow we have to wait for a week or maybe 10 days so that to get that wow expression from the patient. And this technique also helps in operating cases where we have a compromised endothelial profile. So just a routine IA. with the bimanual irrigation aspiration.
Ganen, there's a question in YouTube channel, and they're
Yeah,
asking,
ma'am.
what did you use? What instrument did you use to make side ports?
That was like as what we are all using. What sir has already mentioned. It's a custom made. It's a 22 gauge side port. I think Epsilon or Orolab has got that for us.
It's called as a side port knife.
It's a side port knife only,
Okay.
angled.
And what do you, Gaurav, you hydrated the wounds. What do you hydrate the wounds with? Because that cannula is a little, it's not exactly the way, you know, we make cannulas, but the edge of the cannula is a little bent.
Okay.
So that is
So-
another question which, you know,
Okay. So that was Namrata. You must be aware. Like this was being, it was designed by Harshul Turk, and you know he uses it for hydrodissection also. I didn't like it much for hydrodissection, but I prefer to use it for the sealing, and he also uses it for that. I find it very useful because my previous cannulas, which I've used for donkey's years, they used to be a little longer, so they would have less control. And you know, if you were trying to seal the side port with a very long angle cannula, it doesn't give you great control. The one which I'm using now is the Tuck cannula, and it has a very small, like 2 mm bent tip, and it's blunt. So it goes in very nicely, and you can kind of rotate it on either side, to the left, to the right, to the roof. Sometimes even the floor of the incision, I can hydrate with it, and it gives you a very good control on sealing the wound.
I think Dr. Gyanan, you've implanted the lens effortlessly. Absolutely.
It's a hydro implantation, and just for the viewers, I'd like to mention one thing, ma'am, that the overlay that most of the people are seeing, it's not actually the overlay that you see in the microscope. So with this RTVO platform, so you have to see on the monitor with a 3D thing, and then you have to align your toric lenses. So later on it becomes easy, but to do it for the first couple of times was really tricky.
Yeah, it is, like I said earlier, also, it is really tricky. And like you said, very well said, in fact, that in the eyepiece, you will not be able to see the overlay, but on the screen, which is there on RTV, you are only able to see the overlay.
Yeah. So you have to get used to facing the screen and
Doing it.
aligning the IOL.
Yes. And so here one more thing that I would like to mention, that with the torics, when you have finally aligned it and washed out any visco or any epithelial cells from the posterior capsule, that what I'm doing right now. So it's very important to irrigate the remaining 2 side ports with irrigation on. Sometimes, not very frequently, but sometimes we have seen that if we just come out and we try to hydrate the ports, there is some amount of rotation of the IOL. Not very frequent.
Happening. So, Dr. Gaurav, you had mentioned that you use this little short tip cannula. So, I've noticed that with the longer cannulas, when you're hydrating the ports, there's a greater chance of fluid going behind and pushing the lens out of position.
Right, right.
So this
Also,
actually
there's a small risk of, because these are very fine cannulas, you can end up creating a DMD also sometimes if you're not very careful, because the control is not as good. And you know, when I do the hydration, I actually point it away from the endothelium. I point it more towards the anterior. Even if I'm doing the sides, I tend to point it up rather than down, or you know, sometimes by mistake, if your fluid wave goes, I've had in one instance a DMD in a patient who had a very compromised cornea. So that is one more thing that you have to be very careful of. But what Dr. Gyanendra was saying, I think is very important. We keep the infusion on. Can we switch that off? Yeah, so we keep the infusion on and we quickly seal our side ports and the main port. Because you have a stable chamber, the toric lens remains in place. And then once you're done with that, you have only one side port to seal. So the moment you withdraw your infusion, you quickly seal that also. So this works really well for hydroimplantation and even otherwise. Yeah.
Yeah. So just one question on the injection part, because when you're doing hydro, there are some injectors where you're able to just push it yourself and you have whole control, right? I think Hoya has those kind of injectors, but with the Pure C, it is a screw type, right? So you're not actually rotating it. You depend on somebody else rotating while your hand is in the AC. So I would like to suggest to J&J that they should work on that injector.
Exactly. I've been sending the same feedback to J&J that we need to have something different. See, the simplicity is amazing for those people who want to use the unfolder kinds, which has been the J&J hallmark for 20 years. And they were the first ones to actually come out with that unfolder system, which is so predictable. But today, when many of the surgeons are using hydroimplantation, I think, that shooter or the multi-stud kinds, which one of the other companies does, is so much more useful that, you can actually have great control and get inject. So we tend to actually sometimes take out some of our surgeons, including me. We actually deliver the Pure C from the Simplicity into a cartridge and then use the, shooter for that. So I think message for J&J to kind of convey to the senior management. So I think any other questions, and we would love to. Our team is happy to, thank you so much for actually having us over.
No, thank you. I think, Gaurav, you did a great job. It looked absolutely like a live surgery program with the PIP picture in it. And I think we should thank you for this, and as well as Johnson & Johnson for, doing all the logistics and taking care of the entire thing, which they do effortlessly each time.
Yes.
I would, and if Merle, if you have any questions, because I saw YouTube and Facebook, I think from there I've asked the questions which are already there.
No, I think we covered most of it in the discussion when the cases were going on. So I don't think there's much left.
So I think the last case, he used an iHands, and I've also been very happy with the iHands. Do you want to comment anything about how you find it better than, because he now doesn't even use any monofocals, he uses only the enhanced monofocals, and I think most of us are actually moving away from
iHands is the
monofocals.
new monofocal, no? That is
Exactly.
monofocal,
So I
yes.
think it's changed. It's totally changed the way we looked at monofocals, because now patients all accept that, expect the intermediate vision to be at least functional intermediate vision, and iHands is working beautifully with that. Some of them actually have great intermediate and even some near vision, and the ads required for iHands are also very small in our experience. So
I think in our experience, it's around 1.5 diopters, not more than that. Most of the cases.
okay.
But I agree that J&J has done a great job with the planning today. Thank you so much to all the whole J&J team. They've been here since morning, setting up everything and making it like a simulated live surgery. So I hope this experiment was good.
No, this was better than a live experiment, I must say that, because you all were able to discuss all the points simultaneously. And the best thing is that you showed the unedited videos and the cases which were actual cases. So there were learning points in each of the cases. So thank you so much, Gaurav. I know that you can only pull it through. We did 33 live surgeries, I think, in
Yes.
June.
I think Dr. Namrata really made us perform. I mean, there were 33 cases from this OT, our OT complex, and in the AIS midterm, and she was encouraging us and pushing us, and sometimes, kind of reprimanding us, ki tum log jaldi nahi kar rahe. I was getting phone calls from her desperately every 5 minutes, ki Gaurav, move it forward, So we really, did a great job last time. Yes.
So thank you so much, and we would like to thank Johnson & Johnson for supporting this, the entire audiovisual team behind this who's made it happen. And I forgot last time, but I am going to remember at this moment in time, Mr. Jaswinder, who was rather from Johnson & Johnson, and he was instrumental in getting us onto Surginars. So we can only say our tributes to him for starting this, and just a way of remembering him. That's all.
I remember just, Namrata, we had done a webinar, 2019, and when Surginar started, I think that time too, the second Surginar was from our place, and Jaswinder was instrumental in that. And I remember you conducting that so amazingly with Rajesh and Saurabh Chaudhary or somebody. And that had the highest views ever, for a long time. And that was Jaswinder's hard work. And I think now their team is again putting across a very good show as well.
Yeah, and I would like to thank Sami. If you can show your video, you are behind the video, behind the scenes. But thank you so much for organizing this. And Sami has been doing it Surginar after Surginar, dealing with all the logistics. And I think the most important is that we got Merle today, because Merle Fernandez is difficult to get otherwise. So I think that was the best part. I mean, he actually told me, I thought, he's probably not talked to you. And I asked him, I said, have you talked to Merle? So he says, yes. So thank you, Merle, for being there.
Pleasure to be here.
Thank you so much.
Thanks, Dr. Merle, and thanks, Dr. Namrata, for all your efforts.
Thank you all.
Thank you.
Good.